visitor presentation. Tonight we have Dr. Richard Scott from Carver County Public Health is joining us tonight. And he's going to give us the latest update on the COVID-19. And before we start, Dr. Scott, I just want to say thank you for all your willingness to meet with us regularly. I know you've been at our EOC meetings on a regular basis and always keep us informed and keep us up to date. So greatly appreciate all the work you've been doing. I know it's been a crazy time. I don't know that anyone can really explain everything that's been happened over this time period. So thank you for all your efforts. And with that, I'll turn it over to you.
Well, thank you, Mayor Winchell and members of the council. I appreciate this. It's an honor to have an opportunity to update the council on what's happening in our community as it relates to the pandemic. Obviously, this has been unprecedented times that we've seen over the course of the last 8+ months now, I think, moving on 9 months. And obviously, even just the last couple of weeks have seen some unprecedented activity as it relates to the pandemic. So I am going to share my screen for people and hopefully, so here we go.
Yeah, it's working.
Here we go. All right, good.
There you go.
I do have quite a few slides, but I will be going through many of them fairly quickly. I sometimes have a tendency of speaking a little too fast too, so feel free to ask me to slow down if I'm going too quickly. But hopefully I'll get through the bulk of the slides within 15 or 20 minutes or so, and then we can have some time for questions and answers at the end. But I'd like to start with sort of the national situation because I think it sets a context for us. And then I will share a little bit about Minnesota, and then we'll get into the specifics as what we're experiencing here in Carver County. I think obviously if you've been watching the news, you realize that there has been significant increases in cases over the course of the last month or so. We're beginning to see maybe a slight dip down, but we're not sure if that's really a reporting delay due to the Thanksgiving kind of break, which I think some of us think. So we'll see if that decreasing trend continues. Otherwise, many of us are suspecting that we're going to see another super spreader event from Thanksgiving. Based on what we've learned about how this virus spreads, it often spreads mostly within small gatherings of people, often feeling that they're not at risk with each other, but many asymptomatic folks will then carry it, and then they obviously then spread it to others. And that's where the good majority of the spread has been happening across our community. So we do anticipate seeing another outbreak due to the Thanksgiving week. I guess it all depends on the level to which extent people curtailed their time together. And I know it's really hard to do that. The deaths, of course.
Dr. Scott, if I could,
yes,
a question that I get asked the most, you kind of led into that a little bit, that it's most contagious in small groups. Is there any explanation why one family member can have it in a household, be sick and not healthy, and the other member doesn't get it at all? That seems to be the #1 question that I get asked about how is it if it's so contagious, how is that happening? And I don't know if you got an answer, but I don't know if you can add any insight to that.
Sure. Well, I think you're right in me not having the definitive answer. We're still learning a lot about COVID because, again, first of all of us are at risk, but there are certain individuals that are more at risk, often associated with either age or comorbidity. The why someone can have it in a household and others not get it is still a mystery unless they've done a really good job of sort of maintaining their own space. Often what will happen is that one person may get it and get symptoms, the other ones will contract it but maybe be asymptomatic, and that could be due in part because their immune system is different and thereby may not be as sensitive to that this particular virus. But it's hard to know who's in that situation, and that's what makes it so difficult. But obviously the reason why it spreads in small groups is because you're together in close contact for an extended period of time. Often during celebrations, there's excitement. There may or may not be alcohol involved, but usually there's excitement. People start talking louder, more boisterous. Sometimes there's other activities. There's usually hugging and other closer proximity. And so you can see how then COVID would be more apt to spread as a result of that. And then if you're not aware, and like we've been hearing, is that obviously there's a percentage of people who are asymptomatic, or maybe it's pre-symptomatic. And then they're at risk of spreading it to others, sometimes unconsciously. And we never know who then is going to be the vulnerable one. I think many of you may have heard the story already from Superintendent Devine of Waconia Public Schools. I've shared it in a couple of venues, and he's given me authorization to share his story. But we were meeting with the leadership team, deciding on how to move forward when we first started seeing the exponential growth, and we were considering moving to a more restrictive learning environment. And very soon into the meeting, he apologized for what he was wearing. And he says, well, right now I'm in the waiting room at St. Cloud Hospital, and I don't think my father-in-law is going to make it. And sure enough, he passed away later that evening from COVID. And just a week before, he was active, vibrant, healthy, no reason to suspect that he would have necessarily been any more at risk other than older, but nothing, nothing, probably not too much older than, me, probably a little bit older than me, but so that you just never know when it's going to happen. And so clearly we all are potentially at risk. So that is an ongoing concern. And obviously, as you see new numbers occur, you're going to see a correlated increase in hospitalizations and ICUs, and then of course with that, death. The other thing I think it's important to realize is that deaths are what we often talk about, but we still don't know what the long-term effects can be from people who have struggled with COVID-19. My wife is a nurse at a large metropolitan hospital, and during the summer, they had about one unit that was about half full with COVID patients. Now there's 3, and she is getting stories from people who got the disease back in May, April, June, who are now back with cardiomyopathy, because she oversees a cardiovascular unit and then has a COVID unit within her unit. And then she's had people as young as 20, who are athletic and now coming back with that, who may not be able to compete again. Others that are in their 40s and 50s who are coming back with secondary concerns. And I know when talking with Superintendent Devine, and the last stages of his father-in-law's passing were not pretty. So there's a lot of those other factors we don't always consider that we're still unsure about with COVID. So that's the other concern that we need to be mindful of. So what's happening in Minnesota? I think Minnesota now is finally caught up with what's happening around us. Minnesota used to be an island within the Midwest area with the highest rates were all around us. North Dakota, South Dakota, Wisconsin, and Iowa. Well, it's finally caught up with us now. And so that's why we're beginning to see this exponential growth. And there's widespread community growth. And as a result of that, it's hard to contain it because we're never sure exactly where we're going to catch it. And at that point, you sort of begin to have a hard time knowing how best to control it. And I think that's where we have been as well. And Carver County is no exception. Carver County was an island among its surrounding counties who had a higher rate, but now it clearly has caught up with us as well. This next one shows, I think, the real alarming concern, which is the hospitalizations, the top one being non-ICU, but the bottom one being ICU. And so with that, we will definitely experience more deaths as a result of that. Deaths are obviously a later statistics. ICU is a later statistic from hospitalizations, and death are later statistics from ICUs. And many of you may have heard on the news, but Friday was actually from Wednesday, but it was reported on Friday. We had 101 deaths. That's the most single day death count that we've had since the pandemic started. And I wouldn't be surprised that we might break that here within the next couple of weeks. We'll see. So that obviously is alarming, with a 35% increase in just a 2-week time frame. So clearly a concern. When you look at who's getting it, well, it's across the whole spectrum, but the highest number of are people in that young adult area right here. And they're also the ones that are probably most at risk for spreading it because of lifestyle. And also they're probably least apt to have negative outcomes from it. So there is the sense that it's not going to hurt me. And so combine that with their normal way of living and gathering and connecting and going to bars and restaurants and socializing really does contribute to the spread, because they all know other people who are older or more vulnerable. And also that it's often associated with sports in that area as well. The testing in Minnesota is one of the positive things. We have done more testing than what he anticipated. I think many of you may remember when the governor was shooting for 5,000 a day. And as you can see here, we've had up to 60,000 a day, considerably more than what we have. And what's good about that, while the testing itself doesn't cause it to go down, it does give us a more accurate picture of where and why it's happening that allows us to do better planning and mitigation strategies. The increase in cases, though, are not due solely to the increase in testing. If that was the case, we would actually see a decrease in the positivity rate. But while the cases were increasing, the positivity rate was also increasing and almost at a faster pace, which means that the real reason why we're seeing more cases is because those cases are actually out there and we're just finding them and not because of the testing. Now we see a little dip down here, so we'll see what happens. But again, a lot of us think that might just be a reporting artifact from Thanksgiving. So moving on to the county, I think we are now following a similar pattern to what the state has been. As you can see, our increase of 7-day average increases is considerable. Again, this is the same statistic that the state uses for the safe learning plan, but this is a 7-day average instead of 14-day average. So it's a little bit more real time. Again, it started to dip down a little bit, which is good, but we'll see what happens if that continues to be the case. Our number of deaths, though, has been a concern. We've been fortunate that we've had fewer deaths per population than what we see across the state. But in the month of November, we had almost half the amount of total deaths that we experienced since the pandemic started. I remember you may recall the article that came out when our first person who passed away from COVID, who was in the 50s. There's a big article about that. Well, from that to now, we had 7 in November, and it took almost that many months to get to that same. So that is a concern, and is reflective, of course, of the number of cases that we've had. This is the graph of the official 14-day case rate that schools use to begin their conversation on what safe learning model they're to use. When we were meeting with Superintendent Devine and many of the other school districts a couple of weeks ago, at that point, we were still under the 30 mark. And we said, well, based on our real-time data, I would suspect that we're probably closer to 70. And now looking at this graph, that's exactly where we were. And we said within a week or two, it's going to be over 140, maybe 150, and that's exactly where we are. And keep in mind, 50 is the cutoff for all K through 12 going fully distant learning. And so we're 3 times that rate now. And almost all of our public schools and public charters have adopted, if not a full distance learning, almost a significantly distance learning. Some of our private parochial schools have been resistant to that, and that is a concern. We as a state agency don't have much leverage there, and we can understand their reasoning for not modifying their practices significantly, but that is a concern because that's where we're seeing a lot of our spread now is happening in those private parochial schools that have not moved towards more of that distant learning model. Again, the tests have also increased for us too, which is good. And yet we're still finding people having a hard time getting timely tests. So it's still a concern, even though our numbers of tests have really gone through the roof. And what was fascinating to note that last week, 5.5% of all Carver County residents got tested within that week. That is amazing. I mean, to have that much of our residency, our population, participate in a single request in a week's time is really phenomenal. I think it just really shows the potential of our residents to respond to what's being called for if they're motivated to do it. So that was remarkable. Again, our positivity rate, if you recall, anything above 5% is considered a concern. In order really to see a reversing in the trend of spread, it has to be under 5%. And here we're 3 times that amount. So again, if the cases were only due to increased tests, that would have gone down below because the denominator would have gotten bigger. But in this case, it's actually increased. So that is obviously why we've been so concerned. So the other thing I wanted to talk about, again, is just how does this impact us in other areas? I think we've been hearing a lot about the concern about how COVID has impacted us with our jobs, impacted us with our relationships, impacted us with our other activities, and a lot of times it's those activities and relationships that help us keep us emotionally and mentally healthy. And those things have been challenged, making it more anxiety producing. Also not knowing exactly if we're the ones that are going to get it or what's around the corner, which further adds to our stress. And there have been several studies that have looked at this. A study that was done between October 28th and November 9th showed that 36% of Americans exhibited symptoms of anxiety or depression. So 1 out of 3 of us. Minnesota was really close to the same amount. And that does represent an increase of what you would normally see in the general population as of a year ago. Looking across the age group, all age groups have increased in their reporting of anxiety and depression, but which is really interesting, look at the 18 to 29-year-old group, 51.7%. That's probably represents at least a 30% or more increase than what we would have expected to be normally. Women also, statistically, women will experience a slightly greater self-report of anxiety and depression, but the magnitude here is significantly. And that could be in part because they are dropping out of the workforce for a variety of reasons at a 4 times higher rate than men. It might be due to the types of jobs they have. It may be due to the role they play within the family. We don't know exactly all the reasons. I'm sure it's a combination of many factors, but obviously that is a concern. And then again, when you look at how does anxiety, depression weigh out with the different races, this just shows Hispanic population seems to be experiencing a little higher amount than others as well. Another study that looked at what was been the change since March, since COVID was really starting to we were really starting to take notice of it. Obviously it started before then, but that's when we were really beginning to take notice. And the proportion of emergency department visits related to mental health increased 24% for children, 31% for adults, for adolescents. And that's remarkable because the actual visit to the emergency room for everything else was decreasing because of concerns for COVID and other things. And here the mental health related visits were increasing. In August, a report in August showed that 55% reported an increase in the past month of alcohol consumption. That's clearly one industry that's thrived during this time, and 18% reporting a significant increase. That's usually where there's moving from mild to moderate to severe would be considered that significant increase, and 36% reported an increase in illicit drug use during this time. So utilization of mental health services is an interesting story. When we first started going into lockdown and many services, both health and medical and mental health, were asked to sort of discontinue face-to-face, it took a while for many of the mental health facilities across the state to kind of gear up for telehealth. We were fortunate in Carver County that we were able to gear up almost within a week. But across the state, and of course, our numbers are included in this statewide survey too, but you can see as a whole, there was a significant reduction from January 15th, which was the baseline, to the middle of March, seeing mental health. But that changed rapidly once telehealth was launched and there were waivers put in place for reimbursement mechanisms for telehealth. And as you can see, it's almost completely rebounded. When you combine all of those factors together, before COVID, this was the number of services that were being provided. It dropped down to under 3,000 in March, and then it went back up by mid-May, and it's probably higher than that now. If you look at those numbers for Carver County specifically, and you compare this year from last year, you can see with therapy visits and medication management, it's significantly increased. Intakes and psych intakes, those are probably close to the same. But as far as the frequency of them being visited and seen and complying with their medications, it all has increased from last year. When you look at the number of calls that come in for 911 and or crisis, other areas, this is primarily service calls though to the Sheriff's Office. It does include Chaska PD though. These numbers do include you folks. And you can see the real alarming statistic here is with domestic violence. I just got done talking with someone today who over the Thanksgiving weekend needed to find a secure, undesignated location for herself and her daughter because being in an abusive relationship. We've seen a significant increase in those calls. A little bit of increase in mental health, but a lot of people are choosing not to reach out So I think that's disproportionately low than what the actual concerned people are experiencing, but that's an alarming figure. You see fatal accidents increase 25%, but because the numbers are so low, we're not sure if that's statistically significant or not. I'm not surprised it would increase, probably associated with alcohol use, but again, it hasn't significantly increased. Another concern about avoidance of care, 41% of US adults delayed or avoided medical care, including urgent or emergency type care. We think there may be several deaths associated that are not in our statistics because of people not getting in soon enough or delaying access to care. And of course, avoiding care has been even more prominent among certain population groups, those with medical conditions, African American, Hispanic, young adults, and people with disabilities seem to be disproportionately accessing care, which is interesting. You'd see that. So what does our future hold? I think, first of all, in spite of the fact that we've had lots of cases, less than 5% of our total population has been affected. That means the pool of potential candidates is still high. You've often heard about the concept of herd immunity, and we would need to reach at a minimum of 70% of our population being considered immune, either through vaccinations or from recovering from COVID. We're a long way from that, which means that we still have a lot of potential pool of further spread before we begin to see this stabilizing. So that kind of gives us an idea of what our future could hold if we don't get control of it, so to speak. The rate of increase for cases, I think, is significant. I know sometimes people have challenged me when I quoted the other day that we had a 320% increase in cases. And they said, well, when you have few numbers, you double it and it may be 100%, but still few numbers. We're talking about significant cases. It took us 166 days to get to 1,000, only 72 to get to 2,000, only 12 to get to 3, and only 7 days to get to 4,000. So you can see where this is going. I think this will slow down now as we start moving forward. But again, I won't be surprised if we get to 5,000 in a week or less, possibly. Again, cases per month. I just gave this presentation 2 weeks ago, and this number on the right-hand side here with the projected amount, we thought conservatively we would exceed about 1,400 cases in the month of November. We had a much higher figure as a potential, but 1,400 we thought would be a conservative number. Well, we've doubled that. These are actual numbers now. So what are some of the indicators that the governor uses? I think many of you are familiar with that, but one of the things that's used is what he calls these Minnesota dial back dashboard. There's 5 indicators that sort of are used as a starting point to determine what the mitigation strategies need to be across the state. Throughout most of the summer, 3 of 5 of those were either in the caution or high risk area. But now we have 4 of them that are all in the high risk area. And the only one that's not is the number of testing, and I can show that in a bit. But here's the positivity rate. You saw the slide earlier at 13.8. It really needs to be below 5, before we can start to breathe easier. No pun intended there, I guess. The other areas are case growth. That's the actual new daily cases per 100,000 residents. So you can see that amount going through the roof. What's good is the amount of testing we're doing. And like I said earlier, that doesn't cure or reduce it, but it helps us have a better, more accurate picture of what's happening. So that allows us to be more thoughtful about the approach we need to take in mitigating the spread. And then the last 2 ones are new COVID and hospital admissions. Again, this red mark is what we considered high. We're still within our surge capacity, but hospitals now are beginning to limit other kinds of procedures. As I'd mentioned before, I know my wife, who works at a major metropolitan hospital, had about half of the unit was sort of filled with COVID during the summer. Now there's 3 units of that. And it's not just the availability of beds that's a concern. It's the availability of qualified trained personnel to care for those patients. I know they've already had to adjust the number of patients per nurse throughout the hospital systems because of availability, and that will continue to get worse as this continues to expand. And also with that comes sad stories. I know 2 really sad stories that I heard recently. One was an elderly gentleman that his wife had brought him into the hospital because of COVID. was hospitalized, ended up having to go in the ICU. But within a couple of days, the wife came down with it. She ended up experiencing it, had a worse response to it. She ended up having to go to Mayo, and she ended up passing away before the husband was able to fully recover ICU. And so here's this person who was recovering from ICU just to learn that the person that drove him to the hospital died before he did. I heard another story the other day where someone was admitted, and during the time of being intubated and of course being unconscious during that time, woke up only to find out that 2 of the other members of his immediate household passed away from COVID while he was in the hospital. I mean, these are heart-wrenching stories. So the reality of this is very real for those who are affected. But it's just weird how it doesn't seem to affect others and yet affects some of us. So what's our action plan to move forward? I know I sound like a broken record here, but clearly the evidence is becoming ever stronger of the efficacy of masks. Masks by themselves are not enough, but it's still probably one of the single most important things that we can continue to do well into the time we start getting vaccines to help reduce the spread. And here in this study showed that there was almost cut the rate in half by those communities that required a mandated mask wearing. This is another study that just shows the one-to-one comparison. The more people use masks, the lesser the rate of spread. And again, the other concern we have is that 8 out of 10 cases spread at locations where people gather in close proximity, bars, restaurants, and gyms. And then also what's not listed here is those small family gatherings where people are together, close range, for extended period of time. There's hope around the corner. I think many of you heard in the news. Pfizer is if they didn't get approved today, I haven't heard the news yet, but it's going to be probably this week. Moderna is just around the corner, and there's actually a third one that's probably going to get authorized before the end of the year as well. And so out of all that, there's 13 that are in that phase 3, which is the final phase of testing. But look at all the other ones that are on the bench, coming up. So we're going to have lots of options for quality, safe, effective vaccines. But again, they are not going to be available for the general public probably closer till the end of March, early April. Hopefully, though, we'll be able to start vaccinating kind of those high priority groups, those that are critically caring for the sick, caring for the elderly, and those who would be vaccinated first. But even before the whole end of the year, there should be enough available vaccine to equivalent vaccinate 7.5% of Americans. That's pretty remarkable. So there is hope, but until then, we still need to kind of contain that through the other tried and true methods. So what can we do? We're really left of just controlling what you can control. Steps to care for yourself and your kids. Take care of your body, eat right, exercise, get plenty of sleep. The same things that we recommend for maintaining your health anyway is really especially important now with COVID, because that is directly responsible for you maintaining your immune system and dealing with your mental health as well. So we surely encourage you to do that. And again, try to limit the use of alcohol and or other drugs to self-medicate, because that ultimately just makes things worse. The other thing is to connect. We're social beings. While we may not always be able to be in person, we can do it other ways. I know one of the ways we celebrated Thanksgiving, we were hoping to serve as a host to our youth exchange student. We become sort of the second parents to him because he graduated from Waconia High School about 5 years ago. Ended up going to college here at up in Moorhead. We have sort of been his surrogate family until that time. And his mom flew in from India a couple of weeks ago, quarantined for 2 weeks with the intent of coming to visit us, stay with us for a few days in Thanksgiving. But obviously with this most recent recommendations and the spread, we said we really couldn't do that, and they understood. But what we decided to do instead is to hold sort of a extended family Zoom call. And so we have family members living all over the world, and we all got on the Zoom call at the same time. We had people from Singapore, people from multiple states in Minnesota, and obviously our friends from India, all on Zoom, all at the same time. It was amazing. And I don't know how many total people we had, 14, 15 maybe. And then we just all went around a round robin, spent a couple of minutes updating us, and we probably got a better connection with each other that way than we would have ever had if we were in person. Obviously, it's still not the same, but there's no way that all of us could have been at the same place at the same time without that. So it's clearly important to take the time to connect. Obviously, taking breaks Take time to unwind, learn how to say no when you can, and do the activities that you enjoy, and make sure you spend at least some time outside. Get outside, walk. We're excited about partnering with your Park and Recs department to see how we can make more opportunities for people to embrace winter outdoors, learn to like something that they may have not in the past. But as a result of that, they'll get fresh air, exercise, and also will help with their mental health. Avoid necessary stressors. And one of them is just turning off the television, limiting your exposure to the media, especially when it's nothing but bad news. Obviously stay informed, but limit that. And that's especially important with your young kids. And then feel free to ask for help. And sometimes it might just be calling a friend. Other times it might need to be reaching out for some mental health professional help. It's sometimes something that we all need at some stage in our life. So feel, and again, I'm saying this to the audience, your listening audience as well. Make sure you feel comfortable to do that. We have some of the best resources for that here in Carver County. Obviously, feel confident to talk with your children. Be honest, obviously age appropriate, but don't hide the reality from them. They need to know that you can talk to them about it and that you're going to be okay, that you'll get through this. And then obviously those of us as leaders need to set the example by taking care of ourselves and modeling that for our staff and our colleagues. One other thing, I love this slide. It says, you need to find your happy place. And that starts with first, focus on what you can control. I won't go through all of these 16 areas. You have a copy of this presentation. It'll be made available on your website for your participants and your community listeners. But again, it is important to sort of make sure you're being attentive, not as a second thought, but as a high priority, scheduling in time to take care of yourself, because we want to be in this for the long haul. We want to finish this race victorious on the other side. We want to take those steps now to protect ourselves now so that we can have many more years to come in the future. With that, I just have a whole list of resources. There's national resources, state and local resources. Again, you have access to this, so I won't spend too much time on it. But there's lots of support out there for people to help them through this. And together we can definitely make it. So with that, I surely will open it up for other questions.
Questions for Dr. Scott?
And Dr. Scott, thank you very much for joining us and presenting again. I certainly appreciate all the work that you do, have done throughout the course of this, all the work you do during normal times too. One of the questions that has been on my mind lately was the concern about like hospital beds and staffing. So a number of people said, it's, I hear around like, oh, it'll be fine. If I get COVID and I have to go to the hospital, I'll be good. They'll still make sure that, there's enough people to take care of me or whatever. But, then there's that concern of like, well, there's a limited number of ICU beds. Physically, we're just capped at that. And, even they expanded under emergency circumstances, there's a certain number. Where are we at in terms of actual capacity, like within Carver County? And then the other piece of it that you alluded to is that there's also a staffing challenge too. So what's like a normal staffing model for a number of like patients per nurse versus where does it start becoming dangerous or tenuous, and where are we at related to that?
Well, it's a very good question, Council Mike. First of all, we're still well within our surge capacity of ICU beds. So, we have, I think, plenty of beds still to care for that. I think we're concerning where we're going. And if we continue this trend, we will have to look at other alternatives. But as far as the actual physical capacity, we have that. What's probably more concerning is the availability of quality trained staff. Part of the reason why we've experienced a significant death rate from COVID-19 than what we saw early in this pandemic is that we've just gotten better at treating. Now, we have had some therapeutics that have helped in that arena, but we've also had medical personnel that have gotten real good at fine-tuning their clinical intervention based on what their experience has shown them. It's not something that you can just look in a book. There's not an algorithm for cure. But it comes from that experience of boots on the ground, mind in the game that they've learned through experience over the time. And that's not something that you can easily transfer to somebody else or for somebody else to quickly pick up, which means that as those healthcare professionals get overly taxed and start to burn out, they're not going to be available to care. And therefore, other medical professionals who may not have had the experience are going to have to come in and fill in. And by definition, they're not going to do as good of a job. Not that they're not capable, they just haven't had the learning curve yet to do that. And as a result, we're going to probably see greater deaths because of our inability to respond to the same level. We'll still have the therapeutics, so it probably won't go back to where it was, but it's going to be a concern. But what you don't see is the heartache. And this might bring tears to my eyes. When when my wife comes home crying because her staff are crying because of the stories that they've heard, and they're living with this, day to day out. And so they're seeing the trauma that it causes the families who are affected. The rest of us don't see that as much yet. Many of us are removed from it. But it's very real for those healthcare providers who are struggling with the day to day out. And so the mental toll on them, let alone just the physical exhaustion, is amazing. I mean, when we had our family gathering, my wife and I were the only medical people. Everyone else was like, oh, I've had time to organize and clean my house and paint. And my wife and I look at each other, oh, we'd envy the opportunity to have to do that. And so that's a section most of us don't see. And so that's the other reason why you hear a lot of nurses and healthcare people pleading to follow the guidelines that are being suggested, because otherwise we'll end up seeing you or your loved one at the hospital. So that's a real concern there. The other thing is that healthcare professionals, they're adaptable. They find workarounds, they find a way because they're committed to providing the best possible care they can. And so while there may be an average caseload for a daytime nurse in a relatively intensive care, not an ICU, but in other words, like a step-down unit, might be 4 patients per nurse. And now they're being asked to take to 5 to 6. So they're doubling a 25 to, 20 to 25 to 30% increase in caseload. They're able to adapt because maybe they don't spend as much time talking with the patient. They don't give the back rub. They don't do some of the other things that were important, but maybe not as essential during this time. And so they cut back. So they're able to adapt. And also many, electives are being put on the back burner. And one thing about elective procedures, if you wait long enough, they're no longer elective. And by that time, you might have lost the opportunity for early intervention. So there's a cost associated with that as well.
So,
Sir Mike, I don't know if that answers it.
Yeah, I think it does. And I just had one follow-up question. So one of the things you allude to is that there's this burnout. And I've heard that in some, early on when the surge was in like New York City, there's nurses and doctors from other parts of the country flew there to help provide relief and support. But, now when it's across the nation, there's nowhere else to draw from. So, and I've heard that there's been challenges with retention of doctors and nurses because, they are just getting burnt out. And, when there's this emotional toll every day, like being in a war zone, and I hear that from people who are in the clinical setting. It's, are we seeing that same challenge within communities in Carver County too, where, we're having, retention challenges?
It's a good question. I can't speak to Ridgeview, which is obviously our primary hospital here, or speak necessarily what's happening in the clinics, but I think it's the hospitals where you would see the biggest challenge there. I know that Daryl was sharing last week on our Monday morning briefing that they would see a couple of, COVID-related cases in the emergency room, and now their emergency room has been overrun by COVID-related patients. So clearly, there has been a significant increase. And having to convert more than a single unit, multiple units to COVID units is another indication of that. I can't speak to the exact numbers though at Ridgeview, but I know that that's common across the metro. I'm assuming we're experiencing similar now. As far as being able to bring in, often, as you know, hospitals will often bring in travelers, right? That's the typical way they bring in additional help. You often see it if there's a nursing strike. The big nursing strike we had here about 2.5 years ago, they had to bring in travelers to sort of do the minimum care while they struck. Because there sort of seems to be a shift. I mean, right during the summer months when things were getting hot, we saw a significant increase in cases in the southern part of our country. Now that it's getting a little cooler there, they can kind of go back outside, whereas it's getting colder up, much cooler here, we're having to go inside. So we're seeing the higher cases now happening in the Midwest area. So you're going to see a little bit of transfer of care. It usually isn't enough to make up the difference. But fortunately, some of the major hospitals were able to get some travelers in to help out. And that does alleviate the burden. That comes at a cost, however, a cost that the hospitals right now probably can't afford, but yet realizing it's something that they have to provide.
And one last question. So I promise my last one here. So I've heard of some people saying that, oh, well, they're just trying to get the hospitals are claiming more diagnoses because they're getting more money per patient. Is that true? And what's the economics behind it?
I think the CEOs of many of the major hospitals spoke to this question, I think a week ago at the governor's conference, and they shared how much money they're losing. I mean, it's amazing how much loss of revenue they have generated. So the notion that they're making money off of COVID, from their point of view, is absurd. And the increase of reimbursement for positive COVID cases are often to help offset the added increase in PPE or other procedures that need to be done to offset the costs there. And it's lucky if it even comes close to breaking even. As far as reimbursement for physicians or other things for COVID-related diagnosis versus others, from what I've heard, that is just not true. That is not true. So there's no incentive for the healthcare industry to exaggerate the number of deaths or associated morbidity due to COVID. In fact, the reality is it's probably less than what's being reported is less than what's actually out there. And again, I've heard a couple of stories where a person actually had COVID, but they had another pre-existing condition and they were on their last few days of that. They did not consider that a COVID-related death, even though they had positive for COVID. But the physician clearly felt that the way the patient had died was not associated with the way a COVID patient would die. But if a patient who has an underlying condition, but yet is still healthy and would have many more years to live if they didn't experience COVID, but got COVID, and as a result of their precondition, they died, then yes, that would be a COVID death, but they wouldn't have died if they didn't get COVID. And so, they might have died sooner than somebody else without any preconditions, but they still had many more years of productive life left. And yet those were cut short because of COVID. That then would be considered a COVID-related death.
Yeah. Thank you very much, Dr. Scott.
Good questions. Thank you for those.
Anyone else for Dr. Scott?
I just had one quick. I tend to try to focus on positive things because my profession here tends to be a little bit of a COVID-related HR role right now. So I talk about COVID every day. I'm just curious. I started to see some reports about immunity. Originally I think the recommendation or the thought was 3 months immunity. I think there was a report out, I kind of saw different articles that maybe suggest that there's some longer immunity. I'm just kind of curious of what you're hearing or seeing and what is still the guideline for a general consensus of if you had it earlier, you're immune for how long?
Councilman John, that's a really good question. And again, we don't have the definitive answer yet. I mean, we haven't even been experiencing this for not even a full year yet. So we will definitely learn. And there's always exceptions to the rule. Generally speaking, the common belief is that when somebody who experienced COVID enough to have symptoms has recovered from that their immunity would at a minimum be at least 90 days or 3 months, but could be as long as 8 months. We just don't know if it's longer because we haven't been around long enough yet. I mean, so and then 5 months they thought was sort of going to become the average. And yet there was still enough people that were coming down with a new case, not a resurgence of the old, but a new case of COVID before that time. So then it's, okay, well, so they scaled it back again for most policy related reasons for the 90-day rule. So typically for schools and other areas, if somebody has recovered and they're fine 10 days after the onset of their symptoms, for all practical purposes, they would be considered at low risk for either contracting or spreading COVID for at least 6 months. If they, except in this case for 90 days. So in other words, they say basically it's not really a get out of jail card, free card for 90 days, but basically they can go back to work, they can go back to their activities for 90 days. There have been exceptions to that. And so if they're going to be visiting a family member who's at high risk in a nursing home, you would want to check with that nursing home to see what their policy is there, because it's not absolute. It's good enough for the vast majority of our work. And so we have to weigh the risk balance of everything, because obviously not going back to work creates its own cost and suffering. And so we have to balance all those things. So 3 months is still the guiding rule. There have been some studies out there that may think it's closer to 8, and that's hopeful, because it's studies like that that help also give further credibility for the value of the vaccine. I think most experts will think that it's probably going to be similar, though, to the need to have annual boosters, much like we do with flu. Even though hopefully we would know with flu, of course, it's a different strain every year, but with COVID, we would know, and there might be a need for a frequency of boosters. We just don't know that yet. The 2 new vaccines that are coming out, they're both 2-dose related vaccines. There are some doses. Johnson & Johnson is doing one that's only going to be a single dose. But the 2 doses ones will achieve close to 90 to 95% efficacy for a period of time. We just don't know how long yet. Does that answer your question, John?
It does. Thank you.
Anyone else?
Yeah, you kind of touched on a question that I had in regards to people that have previously had contracted COVID, and with the vaccines rolling out, were they, needing to get that? And it sounds like kind of by your answer, that's still a yes, kind of in order to.
Councilperson Taylor, I'm not sure. Can you repeat the question? Are they needing to get a vaccine even if they recovered?
Yeah. So if someone has recovered from COVID, when the vaccines start to roll out, is it still encouraged to go get one?
That is a good question. We brought that question up just last week. We didn't come with an answer, and unless there's some new information out there, I do not have the answer to that. That is a very good question. Typically, there's not harm in getting a vaccine for something that you've already may have immunity to. Typically, that's not the case. And I'm assuming that would be the case here. We don't know that for sure. But when you have a limited dose and a limited availability of a high value vaccine, then the question is, would it do more good to give it to somebody who hasn't successfully recovered? Because a person who's successfully recovered at least has some level of immunity, therefore would be more apt to be protected than someone who didn't. And then the question is, do we want to use up a vaccine right now for that person when it could go to someone else who hasn't recovered?
I had a couple of other questions. Testing. So, testing is, like you said, we're administering a lot of tests. I've heard a lot of, so as the cases have increased locally and statewide, the rate of getting those results back has slowed down. What is the typical turnaround time of tests currently? And like a secondary part of that, where's the best testing site? What is the best method? I know there's a lot of different, there's the saliva test, there's, testing sites. What's the best for people?
That is a complicated answer because it depends. For the average person, the average resident who wants to get tested, whether either they're symptomatic or asymptomatic, there are several options to them. The saliva testing has been shown to be very highly accurate. And so that has a high accurate results, just like the PCR, which was considered the gold standard before. That's the nasal swab test. That's the diagnostic one that they use, although saliva now can be used for that purposes too, for the most part. Both highly accurate in its ability to determine whether or not you have it or don't have it. They all have false negatives and they all have false positives, but fairly positive. When the saliva testing went from a pilot, and of course, Carver County was one of 24 counties across Minnesota that are part of the pilot, you were able to, when you ordered, you usually got it within a day, 36 hours. And if you submitted it before the afternoon, before the UPS pickup, then they would let you know what the results were basically almost in 36 hours, maybe 48, I mean. Now, because it's been available statewide, there has actually been a shortage on some of the reagents and some of the supplies necessary. So it can actually be up to 5 days before you even get the test. Hopefully they'll catch up with that real quickly and it'll be a fairly quick turnaround time. The other option is if you can drive to what they call the no barrier sites, which are often provided with the support of the National Guard. And they're spread out across the state, and they have permanent sites and usually 1 or 2 time temporary sites. And all of those are available on the county's website or on the state's website if you go under testing. And those usually have a 24-hour, a 48-hour turnaround time. They're often using the mail, but they have kind of a high priority preference given. So if you can get in, those are usually pretty quick. Healthcare personnel often have reserved tests that are available for them. Some of them use a rapid test. Some of them use a traditional PCR test, depending on the need. And those usually also return back fairly quickly, but that's because they're given priority because they're a healthcare person. And so as a result, others would then sometimes have to wait. But that has been a concern. But what's amazing, when we looked at that earlier statistic, close to 60,000 people got tested. Whereas we were hoping to get to 5, right? And even in Carver County, we were at 5,700 in a week. Whereas we used to be happy with 400. So the sheer number, and yet people are still wanting to get tested and we're still delayed. So it just shows that the need for the testing is still out there. Yeah, it's hard to be real specific. So that's why we recommend kind of looking at a variety of the options. We try to keep our website up to date with where those testing options are. You're always welcome to call your doctor because the clinics are also often doing testing for their own patients, not necessarily for the general public. There may or may not be a cost associated with that. There's no cost for the actual test itself, but there might be a cost associated with the clinic visit and the assessment if you go to your own doctor. And insurance, co-pays then may apply. The saliva testing is 100% free, no cost to the person, and the barrier-free testings, those are all free to the person.
I just want to comment. The one thing that I've heard, and I guess this feedback, right, is testing for asymptomatic people, like through exposure. I think that's been a challenge, continues to be a challenge. So, like I said, I alluded to my role. If someone's been exposed, we tell them they need to go get tested, and we quarantine them. And sometimes we're getting feedback that, well, I can't get anywhere. They're not testing asymptomatic. I have no symptoms due to exposure, even though the CDC recommends that if you have been direct exposure, you should get tested. So I think, you talk about testing those numbers. That's the area that I've witnessed in my career here as a problem. People are giving us feedback like it's not easy if you have no symptoms, even if you report direct exposure, to find a test. And some of those are the struggles that we're hearing out there now. Again, as we keep ramping up, I think that'll improve.
And that's still the case. I think it is when it comes to testing that's provided by Ridgeview Medical Center. Or testing provided by your local doctor, unless you happen to be in one of those other groups. There is no restriction, though, as far as using the home saliva testing. The delay is just because there's been so many demand for it, and it takes a while for you to get it. I don't think there's any prioritization given to asymptomatic versus symptomatic, not that I'm aware of anyway. And also the same is true with the no barrier testing. They're willing to test anybody regardless of asymptomatic or symptomatic. Those slots fill up quickly. They try to keep some slots available for just walk-in, even though they don't encourage that because it really does complicate the process. But as long as those percentages smaller and they can anticipate that, that is also an option too for people who really feel they need to get it. But you got to drive somewhere. I mean, we had one here in Waconia that you might remember, and we surpassed their expectation. They had the capacity to do 600 tests a day. We did 400 and some the first day, almost 600 the second day, and we were well over 600 the third day. So they were able to use some of the testing from the previous day to do that. And we ended up having over 1,400 for those 3 days. That was a lot more than any of us expected, especially out in Waconia, because people thought that was too far. It wasn't. And that was a 3-day, but that was a one-time shot. And we've worked with Scott County to provide a couple of other one-day events. And we're continuing to look for other ways to expand our availability of testing right now. But again, we still have the saliva testing. There's other ones that are sort of nearby. We're hoping to get one in Shakopee. We'd love to have one back in Waconia. We've been talking with the state EOC to see if we could become a permanent site for that. So we're so hopeful. It was expanded their testing too, just that not to the extent of need. Sorry, man.
Doc, one other quick question. I've heard that they've changed the quarantine now from 14 to 10 days. If you're testing, is that a correct assumption?
I'd have to double check that. I know my staff who are working with this day to day, they're the ones that are up to date on the latest. Usually the quarantine, once you start symptoms, if you're symptomatic, then it's 10 days from the onset of symptoms and making sure that you have recovered. So you're at least at 24 hours without symptoms and not having to use medication to eliminate your symptoms. If you've been exposed and you're waiting to see if you contract it, I was under the impression that's still 14 days because the incubation period can be that long. So whether or not they changed that time, I'm not sure. But there are the two. There's the 10 days if you have it and recover. And then after 10 days and symptom free for 24 hours, you're good. But if you haven't come down with it and you're waiting to see if you convert, that I thought was still 14 days.
Okay.
And typically you cannot test out of that quarantine. So if you go in and get negative, does that mean you come back to work? No, because you may not have converted yet. And that's why the test is showing negative. So that's why you still usually are recommended to be out for the 14 days.
Okay, thanks. All right, anyone else for Dr. Scott? All right, I'm here in silence. Well, Dr. Scott, thank you very much for being with us tonight and keeping us updated. I hope the folks at home had the opportunity to listen as well. It was a great update, and I think that it's well worth it. And hopefully we can at least put your PowerPoint on our community page to have availability to some of that information on there for people to see. So again, greatly appreciate you being here, and I'm sure we'll see you soon somewhere at either back here or at one of our EOC meetings. So.
Absolutely. Well, thank you, Mary Winchell. Appreciate that. Thank you, Council. Appreciate this opportunity to share. Have a good rest of the meeting.
All right. Thanks, Doc. Appreciate it.